So before starting the vestibular rehabilitation, I want to introduce one person who is always for this vestibular part. So the vestibular rehabilitation, I have learned it from the Eric Johnson. He is a professor in Lomalinda University. So when I entered the university, I saw a different department. We all know about it, where we have a musculoskeletal, we have a neurological rehabilitation, we do have a pediatric, we have women's healthcare, but we never seen that vestibular one department is there. So I was so curious to see what is the vestibular rehabilitation, how it is working on it, how it is effective in the physiotherapy. So when I entered in his room. He's a Harvard qualified professor, and he told me that Sharmila, we have a lot of things in the vestibular rehabilitation, but what we are lagging is the knowledge among the therapists, knowledge among the physiotherapists. So I recommend you to share this knowledge to everyone when you be trained from me, and also make them to understand the start the protocols and work on the same protocols. Not everyone should be as the same. So that was, I never changed this PPT, which is he taught me. So I wanted to present with you directly so that even a single word should not be changed, and the same protocol you guys can follow it. So now we are going for the vestibular system anatomy and physiology. So, what is the vestibular system anatomy and physiology? So, everyone should understand that how the vestibular system work on it. So, before starting that, I wanted to go for how the anatomy will work on it. Okay, so this is the basic overview of our vestibular system, how it is working in and out. So the vestibular system is working with the pre-processing, which is input, processing, and output. So what is the input? Input means we are getting a different inputs through the sensation or sensory. So that is called input. So where we are getting all the information through visual, vestibular, and somatosensory, where it is processing through vestibular nuclear complex and cerebellum. It means from the peripheral area is the visual, vestibular, and somatosensory, and the processing centers in the higher centers, and output through the reflexes. So which is we always knows about it. So how we will get the input? We get through the sensory preceptors, or like we get from the proprioceptions in the joints. From there it is going to the brain, and from there it is going to get output. So what is the main concept of this vestibular is these three areas is a major component involved in this. So whenever the patients come to you, you have to check whether input is proper, processing center is proper, or output is proper. Okay, so I can go for other slide. Everyone got the idea, right? Okay, so now we were going for the visual input. So where are the visual inputs happening? It's a form strong inhibitor of vestibular and somatosensory system. So this is the main strong visual feedback you will get it through two pathways. One is medial longitudinal fasciculus and diatus tract, and another one is the vision test and smooth pursuit test, visual cranial nerve examination. So what this slide is explaining you is that how we are getting a visual input, how you will assess the visual input through the vision test to the smooth pursuit test. Okay, so I will explain you how to do these tests in the later. But first understand that before getting in every patient, you should do this test. The next one is the how the eye muscles will be working on it. So when you see the visual input, so you have to see the eye muscles working of the eye areas. So one is the superior rectus, inferior rectus, and medial rectus and lateral rectus, and superior oblique and inferior rectus. So inferior oblique, superior, inferior, medial, and lateral rectus. So how I have mentioned here is this, which nerve is mostly involved in this for the sensory input. So why we have to check in vestibular? Because vestibular is focusing on the balance. So when your balances get affected when you close your eyes. So always when you do the test, you have one is open eyes, one is closed eyes. So always find out with the test. So that was your muscle is not in a control. You were not able to perform the test. So that is the what we will be looking for the superior oblique and inferior oblique all around the eye muscles. And then somatosensory input, which is called a neurological pathway. So you all get the sensory input from here. One is the visual input, second is the somatosensory input. So through spinothalamic tract, through dorsal column medial lemnistic tract, these are the tracks will provide the information to you. So what are the examinations you will do? Tactile, kinesthetic, and proprioceptive awareness. Usually, most of the tests for the somatosensory related to vestibular is the proprioceptive awareness test. Okay, so I'll go for another one is the vestibular input. So vestibular input, which I have seen through, vestibular input is very important for the balance, which is all we physiotherapists not looking on that. So one is we are looking at okay, balance is affected, it is cerebrum or it is cerebellum issues or it might be a proprioceptive. But we have to look into the main part is called vestibular. So whether vestibular is affected, is that person is getting a balance issues. So before going to that, you should understand the vascular supply of the vestibular, nerve supply, and the what are the bone is involved in this. So when vestibular system is complained of artery, nerves, and labyrinth, so it is a complete system. Okay, and it has the main part is called anterior, posterior, and lateral. We can call it as a horizontal semicircular canal, and utricals and saccules. So these are the main components in the vestibular. So please make note of this. Anterior, posterior, and lateral semicircular canal is a very important part which we need to work on it for the repositioning. So this is the part you should work on it in this when the patient come to the vestibular issue. So now I can repeat it one. Vestibular input is getting by how pre-input vision. Balance input is getting by pre-taste vision and somatosensory and vestibular. Okay. So you have seen all the components and what test you can do it. So I can move on to other. Okay. So this is the basic anatomy of the vestibular. Okay. If anyone can stop me because if you don't see anything like I just wanted to know that what you want to have it because it's look like online and we don't have a direct connections. But please stop me where you could not understand and where you wanted to get more idea about it. Okay, and this is the gist which I have provided in the PPT is like, don't go too much of detail in the academic one because we are mostly working on the clinical part. Because end of the day, when you get into the from the college or university, you have to be with the clinical. So you should understand that how to do the assessment, how to do the differential diagnosis, and how to do the intervention. So further, you should understand the part. So the part of the vestibular is the three canals, which is I already told you is the anterior canal, posterior canal, and horizontal canal. So which is it being positioned like this: anterior and posterior and horizontal canal. Okay, and also we do have a cochlea and saccules and utricles. So cochlea is only mainly for the hearing, but saccules and utricles also be more important on the vestibular. So what is there inside all these canals? In these canals, all you have a fluid. So inside the fluid, you have a crystals. So that crystals will provide the sensory stimulus to the brain where I am balancing properly. So when the crystal is moved out from the canal, so the canal is like that. When the crystal is in the saccules and utricles, so when the crystal come out from the uterals and saccules, you will the all the crystal is around the area, so you will get the imbalance. So that is the main component which we are working on it. When the crystal imbalance is there, you will reposition the crystal. I hope you all understand this. And this is the second part. Is the physiology part is involved. How your the push and pull system is happening in the cupula or within the ampulla of the semicircular canal. So how the crystal is sending the sensory information to the brain. So that is the called the physiology part of vestibular. So vestibular main, which is we have to work on it. We have to work on the semicircular canal, which is anterior, posterior, and lateral, and saccutes, which we have to work on it. Okay. So when the crystal is move out from the saccule, so what will happen? So when there is a pull and push system is happening. So it's like same like how to explain to you like that the hair follicles even in the AC nerve or in the some kind of material which is when it is moving it will give the signals when the signals will go to the higher centers when it come out the signals will not go so that's the same happening in the vestibular so what is happening due to this pull and push system so the hair cells or the hair cells inside the vestibular part will send the sensation to the nerves. So that is the main physiology involved in that. And if you wanted to go deep into that, it's a very big topic of physiology of vestibular system. But for currently, due to short time, so I have just given us some idea about that. What is the behind the physiology happening in the vestibular system? Okay. So this is the pull and push system, which I told you when the patient, the hair follicles in the neutral, so there won't be no conduction when there is a movement. So there is a pull and push mechanism is happening. It will release the potassium ions. From there, it will send it to the nerves. From there, nerves will send the signal to the higher centers. So that is the behind of physiology. This all not required. Okay. So now the processing center. So we understand that what is the input center. Now the processing center. So processing center is mainly happening through the vestibular nuclear complex. So this is between pons, medulla, and cerebellum. So this is the area where all our input is getting from the vision, from the somatosensory, from our body, and from the vestibular. So from there, the brain is understanding, oh yeah, this person is now moving in the right side. This person is moving on the left side. So that is the way the information is going. So always when you wanted to give vestibular rehabilitation to your patients, always you just look into that whether he is getting a problem from the peripheral, which is from the input area, or he is getting a problem from a higher centers. So when there is a higher centers problem, as a physiotherapist, we cannot do anything. We have to refer to the doctors. From there, they will find out that what is exactly happening in the higher centers. What is the higher center? Which is called vestibular nuclear complex, which is located in the pons medulla and cerebellum. Okay, and they have the adapting processing occurs in the cerebellum largely has a dampening or inhibitory effect on the vestibular system. So what is in cerebellum has the control of the inhibition of the vestibular system. Cerebrum between pons, medulla and the cerebellum, they have the control, the processing centers. So I will go for other slide. Now the output. So the how the output is happening. Output is already I have told you through that it is happening two main important, which is called vestibular ocular reflex, and the one is vestibular spinal reflex. So vestibular ocular reflex is maintain the gaze stability. Okay. So what will happen when the person is going like when head is moving, so it should be stabilized. When head is moving in the left side, it should be stabilized. So this is mainly obtained by vestibular ocular reflex. So what is that? Is that like head to eye ratio always should be like 1 degree. When you do sudden move, like you can see guys, like when you do suddenly moving, right? Even when you do the rotation sudden neck, and for a second you are not able to control your body, right? Because you are not getting a fast gaze stability. So when you do slow movement, you are able to stabilize. So this is mainly maintained by vestibular ocular reflex. Okay. So vestibular spinal reflex. Everyone knows about it. The spines. So spine always maintain postural stability. Okay. A spine is always maintain the stability of your body. So, how it is maintained through the vestibular spinal reflex. So, these two is a very important part where you want to deal with the vestibular part. Okay. So, I hope you guys understand the anatomy part of that. And what is anatomy part? Input, processing, and output. So, no need to confuse too much of them. That's what I want to give you a small idea about. Input is through three. One is the vision, one is your somatosensory, and one is through your vestibular. And the processing center, it is in the higher centers. It will be in the medulla, pons, and cerebellum. And the output is where? Output is will be through vestibular ocular reflex and vestibular spinal reflex. So this is more enough for the clinicians to practice directly with the patient. So when you wanted to get in more detail about it, you can go through the briefs and slides. So you will get a more idea about it. So now I am going to the subjective examination. So once you have an idea about the anatomy now, so now the patient is coming to you. How we are going to do the subjective examination? So here we put the simple slide is called simplicity provides clarity. Okay, so don't ask too much of question with the patients, and don't make it too much of complicated question with this. So always subjective examination will provide the proper idea where to go. Okay, so what is our main subjective examination? uh, so what is the main our subjective examination is that we have to look into that how much question we can ask the patient. If the patient is coming to you, okay, and patient is telling that I have a dizziness, எனக்கு தலை சுத்துது, என்னால உட்கார முடியல, என்னால எனக்கு வாமிட்டிங் வர மாதிரி இருக்கு. இந்த மாதிரி பேஷண்ட்ஸ் கிட்ட நம்ம எத்தனை கொஸ்டின்ஸ் கேட்போம்? We cannot ask many questions. And நம்ம நிறைய கொஸ்டின்ஸும் கேட்க முடியாது இவங்க கிட்ட. நம்ம கேட்டாலும் இவங்க விழுந்துருவாங்க. So always try to focus on the small question. So this is subjective examination. Please keep as same as like what Dr. Johnson has guided us and what he want to do in vestibular rehab. First subjective examination. Okay. So why we want to do this subjective examination? To understand the clinical hypothesis, to provide the patient rapport. Like patient should have a confidence about it. Yes, I will get the result from this therapist. So this is two main component you have to look into that all subjective. So what is the subjective examination you will do? You will ask only the three questions. What is tempo? Tempo means what is the duration? Okay, and what are the symptoms and circumstances? Okay, in tempo, when you ask tempo means in the duration. So I will go to the next slide how we are doing. Okay, so the main three questions, two components you have to ask it, whether it is acute and chronic. So every patient will come to you, even low back pain, neck pain, shoulder pain. He will ask, எவ்வளோ நாள் உங்களுக்கு இந்த பெயின் இருக்கு? That is a simple questions we have. So in that you have to ask them the patient எவ்வளோ நாளா இருக்காங்க? How long do you have this problem? So he will say that it is started 2 days ago, or it is more than 5 days. I'm struggling with that. So if it is 3 days, don't think of that. Don't ask anything about it. Go for acute. Okay. If more than 3 days, then it is chronic. So when it comes to chronic, then you have to ask two questions: whether it is constant or whether it spells. It spells means it is coming with the seconds, with the minutes, or with hours. Okay, this is the two questions you are going to ask to them. Okay, acute and chronic. So acute is lesser than 3 days, chronic is more than 3 days. The next, what is the part we are going to ask the question? The second question is symptoms. Okay. Actually, if I might have been there in there, I will ask you the many questions about this. Okay, how you will describe the dizziness? Okay, so dizziness is the no one can describe the dizziness. Even if come to me or even if it come to the other people, எனக்கு தலை சுத்துது. So this is only one word they will say. I'm getting dizziness, எனக்கு தலை சுத்துது, கிறங்குது, something these words will come. But no one will explain that what kind of a dizziness is there. So as a vestibular therapist, as a physiotherapist, your responsibility to put them in a four category of dizziness. One is the one vertigo. Vertigo means what they will be. Please guys look into this slide, very important, because this will give you idea about this, how the symptoms they are describing. And this slide will give you directly taken to your diagnosis part. Okay. So when the person has a vertigo, so vertigo what will have? They will say this, what is happening with you? You will ask with them question. உங்களுக்கு ரூம் எல்லாம் சுத்துதா இல்ல நீங்க சுத்துறீங்களா? நீங்க ஸ்டேபிளா இருக்கீங்க ஆனா ரூம் சுத்துதா உங்களுக்கு? So you can ask this question with them. So what they will provide you is that they will say is that spinning. So they will say I feel the spinning. And the second is that okay, தலை ஹெவியா இருக்கா ஆர் உங்களுக்கு வந்து கீழே வர மாதிரி ஒரு ஃபீல் இருக்கா, ஹெவியா இருக்கா? And this is the second question. So they will say ஆமா ஆமா this is the way. And third is that யாராவது உங்களுக்கு தள்ளுற மாதிரி இருக்கா, is that you feel a disequilibrium. That is the third. Okay. நாலாவது what is it? You feel blackouts, blur visions இருக்கா, உங்களுக்கு blackout இருக்கா? So இந்த நாலு question is very important when the person come to you for the symptoms. First vertigo, room spin ஆகுதா? செகண்ட் உங்களுக்கு தலை ஹெவியா இருக்கு, தலை சுத்துற மாதிரி இருக்கா? செகண்ட் வேற தள்ளி விடுற மாதிரி இருக்கா? அண்ட் மூணு உங்களுக்கு பிளாக் அவுட் ஆகிற மாதிரி இருக்கா? So these four is very important for you to find out the dizziness. Okay. So now I will give you diagnosis on this. If the person is telling you vertigo, it means like spinning. So directly you can say that he has a problem in the vestibular. It is not like, because when the room is spinning, it is mainly for vertigo. Okay. Second, if the person is saying the lightheadedness, painness, okay, that is might be a problem of like his glucose level or his blood pressure level is not normal, or his food level, his energy level is going down. Okay. So then immediately what we have to give them, we have to rest them, and then we used to give the sweets if the sugar level is down, and we used to check the blood pressure. So this is called the second one. And third one is the disequilibrium. So what is the disequilibrium? Disequilibrium is showing you that it is the patient is having ataxia. So if someone is pushing me, so probably it might be vestibular or it might be the higher central problem. Okay. So oscilloscope, blurred vision definitely it will not come under the vestibular. It is come under might be because of the not taken a proper food, or might be their energy is low, or might be due to higher centers. Also this is many category it will come for your oscilloscope. Okay. So subjective, why I am spending little more time on the subjective examination is you should understand that what you have to ask with the patient. Not like a normal therapist, no, I have a back pain, how much you will put you in the scales like that. Okay. So you understand that now what we are going to ask is your duration and your symptoms. Okay. What is the next? Oh, circumstances. Okay. Circumstances means like what is the circumstances? Which symptom is improving? Which symptom is improving? Hmm. Yes. Done. Now we are going for the intensity of the dizziness. Okay. Once you have done these three questions, then you find out that okay, now how much your dizziness is coming, whether from 0 to 10 scales, how you will put. So this is the fourth questions you are going to ask. Okay. The first is the duration, and the second is the dizziness, and the third is this, which circumstances is making you more. For example, the people will say, okay, when I go outside, I feel dizzy, or all the time I'm getting, or when I get up from the bed, I'm getting. Okay, the first question is intensity of the dizziness. How much you feel the dizziness? It is 0 to 10 scale, how you will put. Okay, and the main important part which you have to focus is that within 3 days. It's not like a old one. Like whatever the current dizziness you have to find out. And the second is the impact of dizziness. So impact of dizziness is mainly a different base. Okay. So impact of dizziness, what you have to do is like you have to find out from 0 to 30 mild, 31 to 60 moderate, and 61 to 100. How we have a bulk balance scales, how we have like Ashwasti scales for low back pain. Same like we have it here. But this is not required in the clinicals to do it. This is for the research purpose, or you would like to keep your scale of performance, either functional performance, you can use it this one. Okay. And the last one is the pharmacology. Okay, now we did four questions, and the fifth question is like what current medications you are taking. Okay, so if you are taking a current medication, that medication too will create the dizziness. Okay, so some medications, one minute, I'm sorry. I think that, yes, that. So, I'm sorry, pharmacological things you have to see. What is the pharmacology thing you will see? So, some medications will disrupt the ciliary actions. So, that too, what I have told, push and pull mechanism. So, that too will increase your dizziness. So, what are the medications like ototoxic drugs, aminoglycosides, antineoplastic, cystoplastine, diuretics, mannitol, environmental toxins, carbon monoxide. These are the medicines, even the gentamicin, cisplastine, or mannitol. You whenever you see the gentamicin patients like antibiotics, after taking medicines they feel dizzy. This is why, because there is a destruction in the cilia. So that was the brain is not able to control. When this medication has a complication of destruction of cilia. Okay. So before starting, you should ask with the patient like whether you are continuing all this medication. One is ototoxic drugs and antihistamine drugs. So what will happen antihistamine drugs? This will reduce the fluids in the ears. So when the fluid, that what I told you, the crystal fall, when it is that is reduced, the crystal will fall fast. And also benzodiazepines. This is reduce your CNS and Etivon, Valium, so Atravatin, these all the CNS control medication. Anticholinergics is a scopolamine. So this will inhibit the acetylcholine, which is the activations for your potassium on the physiological aspect of the vestibular. So when the person is all taking these medications, you should understand that this is related to the medication. Okay, so you will have to find out. So the first question is how long you have. I'm again repeating you. How long you have it is the duration, and the second is what dizziness. How do you feel the dizziness? Vertigo or lightheadedness or oscilloscopes. These are the questions. And third is which is aggravating your problem. And then fourth is what is the intensity of this, and fifth is what you are under currently now. Okay. So next is okay. Now you got the idea about it. Okay. So I can go for other one. Uh, I think people can hear me, right? Okay. Done. Okay. Yes. Jessica is sending me message. Yes. Done. Okay. So I wanted to go for the port. Sorry, the whatever I said, the server is repeating the same thing. Okay, so you understand about this five until the medication. Okay, now how you will put the hypothesis. Hypothesis means once you find out that whether if it is acute, how you will understand that what are the things will get. So if it is acute, you have to see whether it is because of central nervous system or because of peripheral nervous system. Okay, central nervous system where there is a no point at all. It is because of the brain, so we cannot do anything with that. Peripheral vestibular system is the one we are going to work on it. Is this because of the infection, or this is because of the BPPV, benign paroxysmal positional vertigo? Okay, keep this word for you guys. It's a benign paroxysmal positional vertigo. Okay, or the motion sensitivity. So, I think many of you guys will have this motion. Why I am more involved in the vestibular system means I have a motion sickness. What is a motion sickness? When you are enter in the car, you will get the dizziness. When you are in the bus, you will get the dizziness. You feel vomiting. You feel tired, and also you are reaching the high areas like top hills area. You are getting dizziness. This is called motion sensitivity. So we physio can work for this motion sensitivity. We can reduce the motion sensitiveness. So that is more important for you to find out the patient with the motion sensitivity. I feel like we all are most of them all struggle going by bus. This is because of motion sensitivity. Why we got this one? Our vestibular system is not that much healthy to provide you the motion connection. Okay, so we physio can work on that. Okay, okay. When you find out the patient is having a chronic problem, so what you will feel might be this is you have the unilateral vestibular hypofunction. This is not like one vestibular is working, another vestibular is not working. So this is because of that. It is not acute. Always in the chronic you will get it. And bilateral vestibular hypofunctions. So might be because of that you will get these two problems. Okay. And if the chronic problem is continuous more, it is called multi-depathwayments. This is like a one kind of a condition where you have the symptoms increases when still like when even you were standing, suddenly you are feeling a dizziness. So this is for chronic constant patients or related to the psychological effect. Okay. Okay. So now when we get it about this, the BPV, when the BPV is coming, so like always BPV when it is coming, when you get the vertigo, when you get the angular position changes. Why he put this word is the angular. So whenever the angles of your vestibular system changes, you will get this BPV. Okay. So I hope you guys all understood about this because it's so much big clinical examination. I will share you this all, but first, what I wanted to understand that the main of the objectives of these tempo symptoms, circumstances, medications, and also the intensity of your dizziness. Okay. Once you finalize about the subjective examination, now we are going for the objective examination. Okay. Okay. So usually though, like objective examination is like why professor has put this dog means like this same like a face we do have it when you do the medical screening. So because medical screening is the thing which is finding out the differential diagnosis. Okay, now you did it. You got some idea about the patient's history and patient medical history, patient what whether he has a dizziness or not. Now the next part is the very important part which you have to do is the what exactly happening with the patient. Okay. For the your subjective examination, another one is called medical screening, which is very important. Okay. Why we wanted to do the medical screening? medical screening always to be performed before starting your exams, like before starting your intervention, and also it is performed the nearby areas. For example, whether nerves get compressed or whether your arteries are get compressed. So for that, always you should do the medical screening, which is called the objective examination. So it is divided into the three level. One is the cervical stability, cervical positional, another one is the CNS integrity. Okay. So when you do the medical screening, these three is a very major part you should have to focus on them. Okay, what is the cervical stability? Because when you do the patients of the positioning like this, left side or right side are moving, if the cervical is not stable, you cannot do anything more than that because the patient will complain of pain. So for that, you should always understand that whether patient has the instability, whether your ligament is all intact, or there is some kind of a pressure in the facial joints, or muscle spasm is all there. So this is always you should find out. Okay. Next is the vertebral. One is the cervical stability. The second which we are going to perform is the vertebral artery test. Okay. In this objective examination, what we are going to do is that always before starting the vestibular assessment, you have to do the vertebral artery test. This vertebral artery test is what? VA test, VAT test, or vertebral arterial test, whatever you can call it as. But it is mainly, we'll say that VBI test, vertebrobasilar insufficiency test. Okay, so this test always before performing every vestibular rehabilitation, you should do this one. Okay, the first is your cervical stability, second is a vertebral artery test. So I will show you that how to, I will show you the video. After this, I will show you the video. But before going to that, how to do this vertebral artery test. The first is that foremost, he's a Eric Johnson professor. He's doing with his daughter, and he showed us properly how to do the vertebral artery test. Sitting in a nice and tall, and look straight and keep the person. The first picture you can see, bring the person down and make lateral flexion and ask the counter from 10 to 1. 10, 9, 8, 7, 10, 1. Like this, you have to ask the count. So if the person is properly answering, then his BBA is intact. So vertebral artery test is positive, like sorry, negative. So if the person is like making some blabbering and he could not able to do any counts properly, and also the person is having a dizziness or like person is complaining some difficulty, then immediately you have to brought back to the patient and immediately you have to refer to the your physicians like neurological neurologist or neurosurgeon or like your general practitioners, you can refer to the patients because when the VA artery is not intact, you cannot do any movements. Okay, so this is the second test which you are going to perform. Second is the ocular elements test. So this will give you the input from the eye muscles whether this muscle is getting work or not. I think students, please take a note of this all the test. Okay, every patient comes, you have to do this all the test. Otherwise, you will not able to find out whether it is in the from the peripheral, whether it is in the highest areas. Okay, so this third test, what you are going to perform is the ocular element test. Okay, so what is the procedure is, it's a very simple. Patient will be sitting up straight upright with the eyes open looking at the clinicians. Okay, so if you feel that the patient is uneven eye alignment, like suddenly eyes going this side, eyes going that side, and the eye is not able to stabilize in one place, it means there is no proper input from the eye muscles. Okay, the next test is like look at this picture, how like look nice and tall, look straight. Okay, next one is spontaneous nystagmus test. Okay, oh, same that you ask the patient, ask the person to sit straight and look straight past over here. So whether you feel any nystagmus in the eyes. What is the nystagmus? Nystagmus is like moving in a right and left or up and down. Fast eye movements is coming. Okay. So fast retinal movements you can say. So that is called nystagmus. So when you see the patient, when ask them to see right side, like look pass over, if suddenly the eyes are going with this level, it means it's a positive test. Okay. The fourth test is spontaneous nystagmus test. Okay. Look at this position. You have to sit nice and tall. Even the patient and physios, both of them should nice and tall and look at that. And gaze evoked in a nystagmus test. Okay. For that, what you have to do is you have to keep the pen. I will show you the video. Okay. You have to keep the pen. So pen chin, pen, chin, pen, chin, pen, chin. So like that you have to tell the patient like look at the pen, chin, pen, chin, pen, chin. Then you will understand that whether they are able to get the gaze stability. Okay. So that is called gaze evoked test. And smooth pursuit test is called like you have to keep the pen and move like this up, down, like this way. Okay. So this way you can see. I hope you are getting my video, right, ma'am? Jency ma'am?
Yes, ma'am. Yes,
My my video you are getting. My video you can getting, right? Okay, done. So the smooth pursuit test is like going up, left, and right, and this level. So what will happen? So the person is moving in all the areas, and then they were doing. So this is called smooth pursuit test. Okay. And saccadic eye movement test is what you have to do pen, chin, pen, chin, pen, chin, pen. Okay. So this is the way they are doing this. So VOR cancellation test. This is the test why we are performing is the patient ability to cancel via cerebellum. Okay, so what will happen, So the patient who are inability to keep on target and suggestive possible CNS problem. So what you are doing, you keep the pen here and taking the pen all over there, here and then coming back here. And the same here, all over here. And so they have to look into the pen and then they have to let it come. So I will show you the video after this, okay? Okay, before starting this, I wanted to tell you guys one. So, this is called the medical screening. Okay, first you do the subjective examination, then it is coming to the medical screening, which is called objective examination. So, when you do the objective examination for this patient, so do it within 5 minutes. Your duration is a 5 minutes, and doing with the 5 to 6 test. Okay, the first test is which is all called the vertebral arterial test. Then also the gaze evoked test, pen chin test. You can see in this video and do this test. If you guys will get a time now or like I don't know, Jency ma'am, possible they can practice between together like within two for 5 minutes. That's it. Okay. The first test is you can see patient hands on this.
சொல்லுங்க சொல்லுங்க சரி ம்
This is for VBI test. Jensika, you can hear, right?
ஒரு 50 குள்ள
You can
முடிக்கணும்
hear the voice too, right?
50 குள்ள
Okay. Okay. So now, Jensika, we need to possible to practice in between both, or I can go for the examination intervention. This is called smooth pursuit test.
ஹெட் ஆஃபீஸ்லாம் கொண்டு வருவீங்க ஓகே
Okay,
One is
got it. Now what we have to do is like we can start now, right? Jency ma'am, you can hear now. You're sending me message. So medical screening, I told you that I think video is not able to play, so we can go further. So now you did the examination, subjective examination, medical screening, which is called the objective examination. Now we are going for the proper vestibular examination. So when you do this medical screening, you find out that okay, now there is no involvement of higher centers. It's only involvement with our vestibular. So for the vestibular part, which canal is involved, whether anterior canal is involved, posterior canal is involved, or lateral canal is involved. So that we are going to work on this vestibular pathology. Okay. So what you have to do is for benign paroxysmal positional vertigo, which is called anterior posterior canal, you are doing a test called Dix-Hallpike test. Okay. And the horizontal canal, which is called lateral canal, you are doing a roll test. Okay. These two tests is very important for the BPV. Okay. And the next one is the Dix-Hallpike test. So actually, what happened, the video is not playing. So I will give you idea about this test. Okay, this text test is find out the anterior and posterior canal where there is any canal issue is there. It means the crystal has been come out from that line. So that is we are going to find out. So examines for BPV in a vertical SEC. Procedure, patient in a long sits on table with the head rotated to 30 to 45 degrees. Clinician stands behind the patient, supporting the neck and trach while assessing the patient into supine with the head slightly below the horizontal bone. Position maintained for 60 seconds and return to sit and repeat to the other side. Okay, so patient is will be long sitting 30 to 45 degree and then going back down and holding for a 1 second. Okay. If you feel vertigo and torsional jerk nystagmus beating in a plane on involved ACC, so fast phase beats toward the involved ACC. Pure vertical nystagmus can suggestive of CNS problem. Okay. Like the vertical nystagmus, if you get it, it will be suggestive of sinus problem. Sorry, I'm sorry for the calls. Okay, so what we have to do is the Dix Hallpike test is been
Ma'am, can
performed.
you hear me, ma'am? Hello.
Yes, yes, I can hear. I can hear.
Actually, in our college, due to network issue, the voice is not audible, ma'am, but your slide is sharing. So you can continue your class.
Okay, then no
I
problem.
am the faculty of Cheran College of Physiotherapy. So due to network issues, we not voice is not audible for us, but your slide is sharing with us.
Very clear. Okay, no
Yes, ma'am.
problem.
Thank you.
Okay. So, Dix Hallpike test is done, and canalithiasis, like when you Dix Hallpike is done, we feel that it is a positive, then it is called the canalithiasis. So, when you do the canalithiasis, you should find out the nystagmus part. When you sister under the meeting, so I can call it that. So, but Dix Hallpike test is there. Okay, so now you can view the picture. Okay, how we are performing the disc Hallpike test from sitting to standing, coming down, and rotating and keeping. So when you see that, you can see the nystagmus in the eyes. It means it's a positive test. Okay. Second is a sideline test. So when the patient is not able to perform the disc herpes test in the supine, so you can do in the sideline test. So the sideline test is this patient is unable to tolerate of BPV in the vertical SCC. BPV is a mechanical disorder caused by atricular. You can read this slide. So when this is the positive, it means the person is having a nystagmus. A person is having vestibular problem. You can see how the sideline they are doing. From sideline, holding and keeping down and looking at straight. Now you are audible, ka? Now I am audible. That. Okay. So The Dexalpic test is performed in a two-way. One is in the supine position, one is in the side position. So what you are looking in the, you're looking at the eyes of the patient whether the nystagmus is there or not. So if it is positive, it means it is BPPV. It is, you have to go for reposition. Okay. Next is called roll test. Roll test is mainly performed for the horizontal canal, which is called lateral canal. So this is all the patient in the long sits on table with the head in neutral. Clinician stands behind the patient, supporting the neck and trunk, while assisting the patient into supine with the neck flexed 30 degree. Head passively rotate to one side and the position maintained for 60 seconds. Return to the neutral and repeat to the other side. So, what is a positive test? It is typically positive bilaterally. Side with the strongest nystagmus involve the side of canalithiasis. Side with the weakest nystagmus involve side of cupulorithiasis. So, vertical nystagmus may suggestive of CNS problem. So, this is called the Rolls test for the lateral canal. So for that, how we are going to perform? We can see the first picture. The patient is lying on supine and neck flex for 30 degree and then rotated in the side and again going back to the neutral position and rotate on the other side. So when you feel the nystagmus, it is called positive signs. Okay. Now So this is like ICF model of disability for the BPV. Okay. So what will be affected for the body function and structures, dizziness, activity, whatever bending and head and neck, participation, complete daily routine, and what are the environmental factors? Cervical spine when regarding the grandchildren must perform cervical spine flexion. What are the personal factors? Frustration with the symptoms per DHA and finding an avoidance of activities due to provocation of the symptoms. So why I put this slide is mainly for this is that whenever you have to put your documentation, you have to put with the ICF model. So what are the body function is affected? What are the activities getting affected? What are the participation is affecting? And what environmental factor is exacerbating? What are the personal factors affecting for them? So this is all very important for you guys to put when you find out with the BPV, okay, which is called the vestibular condition. And this all the test which is performed for the semicircular run. Now we are going to perform the test for the vestibular hypofunction. Hypofunction means like the vestibular is not working at all. It not because of the crystal, but vestibule has been having a issue is performing the function. For that, you have to do the head impulse test. What is called head impulse test? So head impulse test is mainly for find out the unilateral or bilateral vestibular functions. Okay, patient seated with the head and neck flexed. Okay, head and neck flex 30 degrees and focus eyes on clinician chin. Clinician then perform passive, unpredictable, small amplitude rapid head thrust away from midline. Okay, so if it is that the patient is having a nystagmus, so it is directly connected with the unilateral and the bilateral hypofunction. You can see the picture here. You are bringing the patient here, sudden rotation and threading. Bringing patient, sudden rotation and threading, like this. So this is called head impulse test. Okay. So I hope you guys got an idea of the test now. Okay. Now we'll go for the intervention. And I don't know, intervention might be, I'm not able to, I think the videos are not coming, right? I will go for the, okay. For the intervention is, what we have to do is, we have to do the benign paroxysmal positional vertigo. So for the intervention, when you find out there is a vertigo, when the canal is having a problem, you are going for canal depth reposition maneuver. The exercise which is you are going to perform for them is a Branderoff maneuver. See, these all the names are like really difficult during the clinicals practicing. So put it or the simple for this one CRM maneuver for the when you write in the documentation you can put them as That's a CRM maneuver for the anterior and posterior canal, CRM maneuver for the lateral canal, and the general exercise which is called Brander of exercises. So what we have to do is I will show you the CRM, what the canal 3 position. Okay. First, what you have to do is the first picture is showing is the positive position. Okay. The person is sitting in that, then the patient had the problem in the right side canal 3 position. What you have to do is you have to rotate them in the left side, hold for a second, like you have to count 60, 70, 80, 90, like you have to count for this, and ask the person to go to sideline. Look at the position of the professor. So he is holding in the neck so that the neck will be stabilized and also the shoulder will be stabilized. So once the maintain of 60 seconds, then again take back to him to the sitting position. And look at the position of the professor where he is coming out. Even if she has a dizziness, the patient is having a dizziness, we can find out easily. So this is called the Canala 3 position maneuver. Okay. And other one is the Canala 3 position maneuver for the roll test. Okay. So what we were doing, Canala 3 position, we did it for the posterior and anterior canal, and this is for the lateral canal. So lateral canal, what we did the test, it is called roll test, right? So you keep in the roll test position and you are bringing back to the opposite side. You can see the picture too, bringing the positive position on the right side, and the second you're bringing back to the neutral position, and from the neutral position you can see the picture of third, you're rotating completely to the patient on the prone position and holding of the seconds, and you are bringing back to them. It like completely rotating எல்லாத்தையும் அப்படியே rotate பண்ணி and bringing back to the position. So இதில் என்ன ஆகும்னா crystal it will go like this, rotate and come back and come to the position. So this is called Kinalit CRM position. Believe me, many patients had got a lot of progressions while doing this Kinalit position. I can show you the some videos, and this is called the right side reposition test. If the patient is not able to do, so what you have to do is you are bringing to the normal positive position and bring back to the other position and make them to the sitting position. So this is on the sideline. Okay, we have seen that supine, we have seen in the sideline, and then we have seen in the roll test, like on the complete prone position. So these three maneuvers are very important when you find out. Okay, now the other question is what it will come, the exercises. Okay, so what exercise you will give to the patient? Okay, this is called brand. After doing the reposition, you have to properly guide them with the proper exercise. What do you have to do? Patient begins in a sitting position and lies onto the side for 60 seconds, return to sitting, lies on other side 60 seconds and return to sitting. I wanted to show you. This is the one. Okay. I think I have put the picture for you guys. No, sorry. Like what you have to do is same what the professor is doing now, no? Kesani maneuver. So the person is coming on the right side and keeping in that position for a while and again sitting back to the position, again third going back and again coming back. So this is called the home exercise program. You can inform all the patients who were coming to you, you did the reposition and follow this position. That is called the brander of maneuver. And also exercises. So what they should avoid and what kind of exercise you have to provide for them. So what the main home program, avoid lying down for a reminder of the day. Okay, so it means like avoid lying down for a reminder of day. It means like you don't lie down on the place where you are having a
இந்த
dizziness.
ஆஃபீஸில் தான்
Okay, avoid bending or turning your head for 24
சொல்லுங்கள்.
hours. Ask for help if activities like shoes,
பத்து
feeding,
முப்பது
bed, or picking something up from the floor
நாளான்னைக்கு.
for
ஆமாம்
24 hours. Like once you did the reposition, these are the things they should follow.
ஆமாம்
Okay.
ஆமாம்.
Sleep in a slightly elevated head position by
ஓகே.
using an extra pillow and avoid lying down on your affected side until you follow
ம்
PCB definitions. Okay. and avoid follow clinician visits within 2 days if possible. Okay,
நீங்கள் ஒரு
and
வீட்டில்
these
இருக்க
are the
ஒரு
home advice you have to provide. Okay,
அப்படியே
you are providing a band of exercise which is called general
நீங்கள் போய்
exercise,
பிஜிபி
and you are giving the recommendations what on this. Okay,
செல்லரை கவர்மெண்ட்
so
பண்ணுறது
this is the put I put as like a BPV. Actually, I did not go for cupulolithiasis. Cupulolithiasis is a big topic. So, guys, you will just focus on the canalithiasis. Maybe next, when we come there, I can come there to your
அங்கே போய் செக்
India. I
பண்ணிட்டோம்னா
can take your practical classes for this. So, what is the first one? When your patient is coming to BPV, you will do the Dexterity test. You found it's a canalithy position. You go to directly to the CRM. Okay.
அதுக்கப்புறம்
When
வந்துட்டு
the person is coming to you with the lateral canal issues, gold test, you will go directly to the CRM. Okay. So when you do CRM, then after that you will do the home
முடிச்சிட்டோம்னா
exercise
அதுக்கப்புறம்
program.
நம்ம
So this is the intervention flow chart when the person is diagnosed with the vertigo, when the person is diagnosed with the BPV. Okay.
சரி
Within a day, we can correct the patient complete assessment, and we can do
சரி
the complete assessment, and within a day you can do the reposition.
சரி
So that is main major component in the vestibular
சரி
rehabilitation.
சரி
Okay. If possible, I think you guys can take a picture. I will try to share it to this PPT to our Jency ma'am. You can go through it. Any questions, anything related you want to ask about the vestibular rehabilitation, I'm always available for you guys. And next time, hope we can get the practical demonstration. I think this is the basic classes which is focusing on the what is the vestibular rehab. When we are trying to come there, I will take you guys practical classes. Okay. Anyone? I think this is the end of the program now.